Liver cancer, once considered a rare and largely alcohol or hepatitis-related disease, is now one of the fastest-growing causes of cancer death worldwide, and obesity is a primary reason. At the heart of this surge lies non-alcoholic fatty liver disease, NAFLD, a silent but widespread condition fueled by excess body weight, poor metabolic health, and insulin resistance. Once a niche diagnosis, NEFLD now affects nearly 1 in 3 adults globally, with rates skyrocketing in both developed and developing nations. The quiet progression of this disease, from simple fat accumulation to inflammation, fibrosis, cirrhosis, and ultimately hepatocellular carcinoma, HCC, represents one of the most underrecognized cancer threats of the 21st century. And because its early stages are asymptomatic and its progression often goes undetected, NEFLD is laying the groundwork for a future cancer crisis in plain sight. Unlike hepatitis-driven liver cancer, which has been partly contained by vaccinations and antiviral therapies, NEFLD has no approved medical treatment and no vaccine. It is a metabolic liver disorder, driven not by infection or alcohol but by excess fat, especially visceral fat. Obesity, particularly central obesity, is the single most important risk factor. As fat accumulates in the liver, it triggers low-grade chronic inflammation, cellular stress, and metabolic dysfunction. In many patients, this fat accumulation escalates to non-alcoholic steatohepatitis, NASH, a more severe form involving liver cell injury and scarring. NASH dramatically increases the risk of developing HCC, even in individuals without cirrhosis, making it a particularly dangerous precursor in populations where liver disease has traditionally gone unmonitored. What makes this trend especially alarming is how widespread and underdiagnosed NAFLD has become. In many Western countries, NAFLD now affects over 40% of adults with obesity or type 2 diabetes. In some Asian and Middle Eastern nations, the condition is rising even in people with lower BMIs, due to genetic and lifestyle factors that promote visceral fat deposition despite overall leanness. Children and adolescents are not spared. Pediatric NAFLD is now a leading cause of chronic liver disease in youth, driven by sugary diets, sedentary behavior, and rising childhood obesity rates. These early life liver insults may predispose individuals to cancer decades before typical screening age, effectively shifting the cancer burden to younger generations. The challenge in addressing NAFLD-related liver cancer lies in its silence. Most patients with NAFLD have no symptoms and do not undergo routine liver imaging or biopsy unless liver enzymes are abnormal, which they often are not. Even among high-risk groups such as people with obesity, metabolic syndrome, or diabetes, NAFLD is rarely screened for systematically. As a result, many individuals are diagnosed with liver cancer only once it has reached an advanced stage, when treatment options are limited and survival rates are poor. Hepatocellular carcinoma has a 5-year survival rate of less than 20%, one of the worst among all major cancers. And yet, the metabolic roots of this disease remain marginalized in cancer prevention discourse. Obesity compounds the danger not only by increasing NAFLD risk, but also by promoting more aggressive cancer biology. In obese individuals, liver tumors are more likely to occur without cirrhosis and may have unique metabolic signatures that make them resistant to standard treatments. Fatty liver also impairs the liver's regenerative capacity and reduces tolerance to surgery, radiation, or chemotherapy. Moreover, obesity and insulin resistance interfere with immune function, weakening the efficacy of newer therapies such as immunotherapy, which have shown promise in treating liver cancer in leaner populations. Despite these facts, public awareness of the obesity, liver cancer link remains low. Most people do not associate excess body weight with liver damage, let alone with cancer. Messaging around NAFLD tends to focus on liver function and metabolic health, often neglecting the progression to malignancy. In clinical settings, liver cancer screening is still largely reserved for patients with viral hepatitis or alcoholic cirrhosis, leaving a massive diagnostic blind spot in the metabolic disease population. Without proactive surveillance, thousands of cases go undetected each year until curative treatment is no longer viable. This gap in prevention is especially dangerous given how common the risk factors are. Obesity, diabetes, and poor diet are no longer confined to high-income countries. In fact, NAFLD-related liver cancer is growing fastest in low- and middle-income nations where healthcare systems are unprepared for its silent burden. As traditional infectious causes of liver cancer decline, Metabolic liver disease is poised to become the dominant driver of liver cancer worldwide, and few systems are ready for the influx. A shift in strategy is urgently needed. First, NEFLD must be recognized as a cancer precursor and treated with the same seriousness as other high-risk conditions. Obesity screening should include liver risk assessments, especially for patients with diabetes or metabolic syndrome. Public health campaigns must educate people about the cancer risk hidden in fatty liver, emphasizing that liver disease can develop without alcohol or hepatitis and that it can quietly kill. Routine liver ultrasounds, fibrosis scoring, and non-invasive diagnostics should be made more accessible and widely used in at-risk populations. Second, weight loss must be reframed as a cancer prevention strategy, not just a lifestyle choice. Even modest reductions in body weight have been shown to improve liver fat content, reduce inflammation, and halt fibrosis progression, dramatically lowering long-term cancer risk. But these outcomes must be made visible to patients. People need to understand that managing obesity isn't just about feeling better, it's about living longer and avoiding one of the deadliest cancers. Finally, researchers and clinicians must prioritize treatments for NEFLD and NASH. With no FDA-approved medications and limited clinical trial data in diverse populations, we are lagging behind the trajectory of this disease. If liver cancer is now among the fastest rising cancer threats, then delaying innovation and ignoring prevention is a costly mistake. Liver cancer is no longer a disease of alcoholics or viral hepatitis patients. It is a metabolic cancer, increasingly fueled by obesity and preventable through better awareness, early detection, and intervention. The silent epidemic of fatty liver disease is setting the stage for a public health disaster unless it is met with the urgency it demands. The clock is ticking, and without immediate action, liver cancer may soon move from a fast-growing threat to a dominant cause of cancer death worldwide.